Hi, everyone. Thank you for coming to our panel today, Aha Moments in Mental Health and Chronic Disease Management. So I know everyone here probably has a different idea of what mental health means, and you probably have varied background in mental health, whether that's from the professional capacity, patient, and otherwise. Everyone here on this panel has patient experience, and we do have, some of us have some professional experience as well. So we wanted us to start off with some introductions and for each of us to go around and just kind of define mental health from our perspectives, and as well as what we think it means for our communities. So for me, my name is Charlie Blotner. I'm a member of the brain tumor community for someone who's had a brain tumor myself, as well as a member of the transgender community. And so for me, mental health means taking care of myself and my community members when those might be stigmatized by others or face barriers that not everyone else might face, or especially within the brain tumor community when our treatment might be really physically taxing. So now I'll pass it on to Allie.
Hi, everyone. I'm Allie. I blog at verylightnosugar.com about type 1 diabetes and healthcare advocacy. And I actually posted a blog about this panel a couple weeks ago, and we received some feedback from the community, so the healthcare community as a whole. So I wanted to just share some themes here. So I have your notes in my front pocket, and these are some prevalent themes that we received from the crowd. And we're going to dive into these in more detail during the panel, but we just wanted to thank everyone who bravely volunteered some feedback to us, and we really appreciate it. So some prevalent themes are access, affordability, and proper understanding of mental health and chronic illness complexities. Mental health screenings and assessments to make comprehensive treatment plans. Early intervention and coping mechanisms. Medical PTSD, the chronic re-experiencing of trauma due to health conditions. And finally, the value of peer support when dealing with current gaps in mental health care.
Hi, everybody. Thanks for coming. My name is Danielle Edges. I am a chronic cluster headache patient, as well as the mother of a daughter born with a very rare medical condition. She has very complex congenital heart defects. Mental health to me means using mental health and behavioral health as a tool to manage chronic illness, to manage the surgeries, the hospitalizations, the doctor's appointments that never end, and for the entire family, not just the parents, but the siblings, as well as the patient in where we have a medically complex child in the home, and how we can kind of help use mental health to make the whole environment just a healthier place.
Hi, I'm Sarah Kucharski, perhaps otherwise better known as Afternoon Napper. I'm really excited to be joining you guys about this discussion. This was a panel I also held, I think, last year regarding mental health and starting to really bring some of these conversations to medics, because it's so critically important that we look at mental health as part of whole person health, and that it's like you take your car in to get an oil change so it keeps working. Why wouldn't you take yourself in to get a tune-up so you keep working?
Thanks, Sarah. My name is Mark Freeman. I run an online mental health community called Everybody Has a Brain, and I do peer support work professionally with people around the world. And for many years I struggled with mental illnesses. And for me, mental health means the practice of being myself within whatever context, internal or external, that I find myself.
Great. All right. Well, so now everyone knows who's here, what perspectives that we have to share. I'm going to throw our first question at Danielle. And so I want to know, what are some barriers to care that you and your family have faced, and what do you think, what kind of impact do you think that will have on you and your daughters down the line?
Unfortunately, mental health for children is a very difficult topic for a lot of people. A lot of times there's just not the therapists available. They don't want to talk to children underneath a certain age. And they say, oh, well, they're not ready to be evaluated. They don't understand the situation or the brevity of the situation. But I feel like these kids who go through these complex medical procedures, complex surgical procedures, they are way ahead of the typical child. And they have to deal with things that they do not have the mental capability to deal with. So if we don't give them that, they can't do it. And I mean, my daughter's 9 now, and we just started cognitive behavioral therapy in March of this year. And we've seen a dramatic difference. So I can only imagine what the implications would be if we hadn't taken that step forward and what it would look like in the future. For myself, I was diagnosed with PTSD and depression about 6 years ago, and just related to everything that we've been through. It's trauma, essentially. And what I've learned is that while it was my trauma, it was her trauma as well as my younger daughter's trauma and my husband. We've all experienced this trauma. So I feel like, we really need to bring these conversations to light because these children need the help. We've created all of these amazing advances in medical technology to make these children compatible with life, where 15, 20 years ago they were not compatible with life. But now we've given them that ability, but we don't give them the ability to be able to live and to have a quality of life.
Great, yeah. And then, Allie, do you think you could kind of talk and speak to that quality of life now as, an adult, and you were diagnosed with diabetes at a very young age, right? And so if you could kind of share with us your mental health and kind of that care you received, if or not, kind of growing up with a chronic condition.
Sure. So I was diagnosed with type 1 diabetes shortly before my 3rd birthday. And in terms of mental health care as a child and adolescent, there wasn't much. I think part of that is that I was quite resistant to the idea. You're type 1 diabetic at the age of 3, so you're getting multiple daily injections, and you learn to put on a brave face very early on. But I don't necessarily think that's the healthiest thing if you're not really exploring how you truly feel. You can be brave all the time, but that doesn't mean that you can't feel things and still have painful days. So as an adult, I think I'm much more in tune with mental health and how it's an ongoing process. Obviously, I have a lot of peer support, a lot of great friends on this panel, and elsewhere in the diabetes community, and just in general, family and friends. And I've noticed lately that it's more in the conversation with my friends, people admitting, today I feel anxious, today I feel depressed, and it's starting to feel more normalized to me. But I definitely understand what it's like when it's not a normal part of the conversation, and I don't want other people to have to go through that. So I'm glad to see medics talking about this more often. And I think the early intervention, like what Danielle just spoke to, it's very critical because you don't want to get to the point 20 years later as an adult where you're like, all right, now I'm going to think about my mental health. You want to start that process earlier and maybe not feel so alone in it for many years.
Yeah, so clearly there's power in language, there's power in community, and every child is different as well. Sarah and Mark, could either of you or both of you speak to any other barriers to care that you think might differ?
An obvious barrier to care is shame. And I know I was first diagnosed with depression and anxiety when I was 19. It was, the first year going to college, and I'm an only child, and so I was really used to hanging out with adults. And then all of a sudden I was expected to hang out with people my age, and I didn't really know what to do with that. And just so much change and everything, and I actually ended up getting physically ill to the point that I went to student health And actually, at first, they wouldn't even let me leave. And they wouldn't tell me why. And I was like, well, that's great, but I have a classics course to get to in like 20 minutes. And they said no. And they watched me like walk up the stairs to a counselor's office. And it happened that that was also Parents' Weekend at the university. And I'm like, how am I going to go and tell even my parents? And they're there and they're waiting on me and they're excited and everything. And I'm just embarrassed because I feel like I've failed. And we go out and I end up separating the two of them and telling them individually. And my mom was a lot more empathetic than my dad. My dad is an attorney, a guy, one of those who is not in touch with his emotional self very well. And so there was some reinforcement of this notion that it was a failing and that I could just like snap out of it. And that, of course, I mean, you don't want to disappoint your parents, you know, and that feeling of shame and judgment made me hesitant to talk to them about it, and not having somebody to talk to about it, someone who you trust, someone who's supposed to be there to support you is a hindrance and an additional layer of burden. Mm-hmm.
Yeah, I was very similar at first too with the like what you mentioned there with the classics course, where you're kind of like, I don't have a problem, I have things to do, and also because I have things to do, I can't possibly have a mental illness, and so because I found one of the barriers to care for me was myself. I'd absolutely say I had so many very rational, totally like very reasonable reasons for all of the compulsions I was doing. So even when things got really bad, so like Ali mentioned there, don't wait 20 years. So I waited until I was 28 to even like notice that I had a problem. And by that point, I was doing things like I would stand in front of my stove and watch it because I had already done all of the checking compulsions. I knew it was off, but I could no longer believe that it was off. So I would have to like stand there and watch it just to see if it spontaneously turned on and burned the apartment down. But I didn't think that was a problem. Like I had reasons for that, because right, letting the apartment burn down and killing all the old ladies and the cats that live, that's bad, right? Yeah. So I was like, no one wants to do that here, right? That's rational, right? Yeah, because if anyone says they want to do that, we can talk later. I know some great resources. Right, and so for all of these things, and I was like, I couldn't hold knives anymore because I would see them, you know, either getting stabbed into myself or other people. I wouldn't go past, there was a school near us because I would see the kids like falling on the ground and their heads splitting open. And I was just spending hours a day on compulsions, but I had no insight whatsoever into that was an issue, because I thought, you know, mental illnesses are for other people. I'm going to school, I'm working, I'm making money, I'm successful, therefore I don't have a problem. And so one of the huge helps was finally not listening to myself. It was recognizing, oh, it's my brain, and my brain is the thing that I'm listening to, so I have to stop listening to my brain. And then I think, yeah, just quickly, the one other barrier to care that I really ran into was just how strange the mental health care system is. And then that's when I was kind of woken up to, I mean, we have this weird system in mental health care where either you can get kind of free treatment, but you have to wait on a waiting list for a very long time. And
you live in Canada, right?
Well, so except we don't have kind of government-funded mental health care. So yeah, I live in Canada. But yeah, so you could see a doctor, right? So if you can see a psychiatrist, then it'll be free. But you probably have to wait a year. And you don't know what kind of therapy you're going to get. And then, or you can go and see someone privately. You're going to be paying $200, $250 an hour. And we don't have this middle part of the system like we do in other kind of industries, right? Like, so like if you're exercising, you don't have to go and exercise with a kinesiologist, right? You go and work with somebody who does fitness, and that's their lifestyle, and you tap into that experience. But in the mental health care system, we don't really have that yet. And so it creates all these barriers. I remember I was in school at the time, and so the school gave you $500 to cover therapy. And then they referred me, so they didn't have counselors. They referred me on to a counselor for what they thought I might have, but I didn't really know what I was dealing with. And so that psychologist they sent me on to was terrible, like fundamentally like a really terrible at their job. But right, they have a steady stream of business, right? I didn't pick them, you know, they just get people sent on to them. And so 3 sessions later, all the money was gone and there was no help. And then I got bounced back around the system, and so that's very common. People not being able to choose where they get help, and therefore consumers aren't making decisions, which means, you know, there's a lot of, you know, not great therapists in the system that people just get bounced around to.
Yeah, yeah, and it sounded like, were you going to say something, Sarah?
I was just, the not listening to your brain part, like,
Yeah, I mean, it's nice and all.
it's nice and all,
Yeah.
but it's nice and all, but don't, yeah, because the brain and the feelings, like, while they're related, they don't necessarily get along. And I've just recently had the experience of, and it sounds kind of egotistical, but it's like when you're smart enough to rationalize, to think your way out of many things, to be highly functioning, as they call it, and that many of those things actually can be defense mechanisms. And I'm learning that using like smarts and capability and respect and like these kinds of things, if I can enjoy that, then I can shut down the feeling part, and it's not as important and you don't get hurt as much, but it strikes a really awkward balance. And so how can we figure out, yeah, how to not listen to our brain? That would be super. That would be really super.
Sarah was speaking about the whole idea of shame and like as a failure. As a mother, when you see your child being, and in the 3rd grade, being suspended for hitting another child, when if you saw my child, she's skinny as a rail, that she could actually have the physical prowess with oxygen levels of not even 80 to attack another child. Talk about a failure. That's a failure. And that's what I felt like as a mother. And so I knew I had to do something, and I had to do something for all of us. We were all suffering. We were all suffering. And that idea of the shame, like, you know, I've been doing this for almost a decade with her. And the idea that I'm breaking down and I can't do this anymore, and that she's been through 5 heart surgeries and all this stuff, and 3 transplant evaluations and 3 denials for transplant, and that I can't do this, it's like I can't be a mother anymore. And if I let people, I mean, I get concerned that because my daughter has secondary insurance through the state, that, you know, her case manager is going to see me on some bad day, and I'm going to have CPS knocking on my door. And these are real fears for this kind of stuff. So it's like, if we don't do something to start providing this mental health care for these kinds of families at the get-go, we're doing a great disservice to everybody, to that child, to the parent, to both of the parents, to the siblings, everybody.
Yeah, I think that's a great segue into our next question then, which kind of speaks to the continuum of care. And I think that there might be a misconception of there's a before, during, and after with the diagnosis of some sort of mental health. And there's really not, you know, it's kind of constant, right? We always need to be taking care of our mental health. And so what I want to ask is, how might we normalize this conversation and start to implement early interventions?
I just think, you know, first of all, we're up here and we're all talking about chronic disease. Well, guess what? That chronic disease ain't going to go away. It's not going to go away. I mean, unless we get a cure, and I mean, we're not there yet. So why wouldn't we just have a continuation of mental health? It's just, it's how Sarah was talking about the whole idea of the whole person, living wholeheartedly, being and looking at the patient holistically, completely. Because I can guarantee you that when I was diagnosed with cluster headaches and I was having depression at the same time, as soon as I got everything taken care of and I started getting into the things that I needed mental health wise, I stopped having the headaches as much. I mean, our mind is so much more powerful than our physical body is. But if we don't get the help we need, it just makes you want to throw your hands up in the air.
Yeah.
It really does.
Yeah. And Mark, so you do a lot of work in this area. What resources have you found to be helpful? What have you found to be not so helpful even? And, when can you seek out care for mental health?
Yeah, and so I think even building on that idea of that continuum of care, because I think it ties into the resources I find most helpful, because I think we really need to start approaching mental health the same way we approach physical fitness. Right? And that has to do with the labels, but also it gets into the resources, because like if you think of physical fitness, like we would expect everybody in this room understands you have physical fitness, right? You have varying levels of physical fitness, and there are contextual factors in your life that affect how you're able to take care of your physical fitness. And we just take that as for granted. And so somebody, if you don't swim and you get thrown in the water and you drown or you struggle to swim, we don't label you as having a drowning disorder, right? If you don't run, right? If you don't run and we take you out there and we say, you have to run 5 kilometers without stopping. Like if you don't run, you're not able to do it. That does not mean you have an endurance disorder. Right? It doesn't mean it's not biological either, right? It's totally biological, right? But we also know we can do things to change that. But we also know it's totally natural to have that experience if we're not doing things around it. And so I found the resources that helped me the most was kind of in the same way that we approach physical fitness, right? You go and you work with a trainer. If you want to run a marathon, you talk to somebody that can run a marathon. And because they understand, how to overcome the same challenges that you have to overcome to do that. And so that's what I found. So peer support resources were the best resources because, so one, in that way I was really lucky that I had no insight. So what's really interesting, now I'm involved in patient communities, I never connected with any mental illness communities because I didn't think I had a mental illness. Even when I was like so separated from reality. And so I was really lucky in that when I finally found a great therapist, she never told me that a lot of the illnesses and the diagnoses which had been stuck on me were things that were generally seen as chronic. And I wouldn't classify as having, like obsessive compulsive disorder, for example, I would classify as having obsessive compulsive disorder now under any measure whatsoever. And so part of it was having that recovery focused resource right from the start, from peer support and from therapists who just said, we're going to do these things and you'll get better but it's about learning skills. It's about learning how to swim. And learning how to kind of jump in an ocean of anxiety and swim through it. And so I was really lucky to find those resources that approached it from that angle of kind of this, like, it's this continuum and you're like, your brain is chronic, but the mental illness doesn't have to be.
Yeah, your brain is chronic, but the mental illness doesn't have to be. I like that.
Stuck with brains.
Yeah.
But we shouldn't listen to them. Yeah.
Yes.
Can't get rid of those, but don't listen to them.
Yeah. Yeah, but don't listen to it. Yeah.
So then, so on the topic of, there's something you said that was so great, but your line just kind of caught me off guard there. So I had something to say, but your brain is chronic and your illness doesn't have to be, just kind of really struck me. I wanted to kind of skip back to language really quick and, kind of self-narratives and peer support within our own self-narratives and language. So Allie, would you want to touch on that a little bit?
Sure. Oh, wow. Thank you. So type 1 diabetes is the context that I have because that's what I know, but I think this probably applies to a lot of chronic health conditions as Danielle said, the fact that they're chronic, it's ongoing. So mental health should be an ongoing part of that. And as a child with type 1 diabetes, we were only really looking at the physical part because it's like, oh my God, you're diagnosed with diabetes, your body's no longer making enough insulin to sustain you, so we need the syringes and the insulin and the endocrinology appointments. And, you know, there's ranges of blood sugars that are that of a normal person that you want to strive to attain. Normal meaning non-diabetic. I don't think any of us are that normal, but you know, with type 1 diabetes, inevitably you're going to fall in and out of that range. And the language is very important, because if you receive messages, you think of how many times a day you check your blood sugar as a type 1 diabetic, maybe 10 times. If you see 10 bad blood sugars, what's that message over the course of a year, 5 years, 10 years, 20 years? I'm bad every single day. So you have to learn how to separate that from it's not a bad character flaw, it's a blood sugar that is out of range, yes, and you need to take action to correct it. But I try not to look at it as the good or bad blood sugar. And I remember an aha moment that I had with this, speaking of the title of our panel. A couple of years ago, I said to my doctor, you know, I know everything that I have to do to manage diabetes well. And if I was sitting here and advising another diabetic, I think they'd be a great diabetic. And she looked at me and said, are you aware of your language? And I'm thinking, like, what, did I swear? My mom's going to be mad at me. I swore at the doctor. And then truly a light bulb went off, and I see myself as the bad diabetic because my numbers are out of range. But I see other diabetics as, okay, they're the good diabetic. And but I also am more forgiving towards, you know, another diabetic in my shoes who is maybe struggling. Because I could see there's so much else that goes into it. It's an autoimmune condition. You can try your best, but you're still going to have good days and bad days. And it's not your fault, even if I think I see a lot of language about, oh, my high school diabetic son doesn't want to wear his insulin pump. Well, he's probably sick of having diabetes, and you have to remember he's in high school. So even if one day he has a bad day and, you know, kind of cheats the diabetes system a little bit, can we really blame him? I think we need to be forgivable and not come off as if we're lecturing people, because this is constant. And even when you're up on stage presenting at medics, your glucose meter can go off telling you that you're high. So, you know, you have to learn to kind of roll with the punches and not beat yourself up, which I'm still guilty of it, but I'm more cognizant of it. And I think that's the biggest part of the battle, is realizing, oh my gosh, this is how I've seen myself, or, you know, the language from the media, from society, even from family members who mean well. You know, we have to be careful in how we portray that message, because it's so constant that you don't want a constant bad message coming at you. It needs to be more empowering.
Definitely, yeah. And so then moving from empowering to patient communities, I think at least a lot of the empowerment that I've found has been within my own patient communities. But sometimes when we're involved in our patient communities, we can get a little too involved, or just with time, we can find ourselves getting burned out. So does one of you want to define advocacy burnout for everyone here?
Well, I'll just go with the community that I live in with my daughter. It's a very, very, very together community. But at times, there are my kids sicker than yours. So on and so forth. And that creates, you just walk away. There were several times, actually, I had the worst one about 2 years ago, where I literally unfriended every heart mom. We call ourselves heart moms. I literally unfriended every heart mom on my Facebook. I left all of the groups because I couldn't take the I'm sick, you know, your kid's sicker than my kid, or it's not a competition. And it doesn't help the mental health either. It didn't help my mental health, because, and then on top of all that, then you see these other kids that don't make it. And it's a total reminder of what you live with every single day. And there's absolutely burnout there. I mean, I had burnout 6 months ago where I was just like, I'm done. I'm done. I can't do it anymore. There's just too much.
I'm going to pretend that I'm not the coordinator of ePatient programs as I answer this. But so my overarching diagnosis is this intimal fibromuscular dysplasia. In rare version, rare disease, whatever, I started a organization. Sounds great. Going to provide social media support for people all over the world. Yay. That means that people all over the world need help all the time. And your Twitter notifications going off, and your Facebook notifications are going off, and your email box is going off. And it's stressful because you end up feeling that you're the only one who is their lifeline. And if you don't do it, who's going to? What's going to happen to this person if you don't handle it? And you keep burning out yourself. And it goes back to the whole, if you don't care for yourself, you can't care for somebody else. And what's been interesting for me is that it's actually given me an enormous sense of empathy for providers, because answering the same questions over and over and over is a drag. And when the community members aren't taking it on themselves to do some research, do some education, get involved, and instead are passing the buck and looking for every answer to be handed to them, and for you to basically take over management of their care, like, it happens on this side too.
Yeah, definitely. Mark, what advice would you have for advocates who feel like they're burned out?
It was funny. This was something that I was helped by a lot of the skills I had to learn with handling mental health. But then even on the frequently asked questions, I have a document of frequently given answers. And so for all advocates out there, it's just you start a Google Doc and you just start to copy in those frequently, because they come up all the time. And so I was like, oh, I'm just typing the same thing out again and again. So you still tailor it to the person, but get a frequently given answer document. Whew, is going to save you so much time. And then the thing that I found that was most important to me, so this came kind of directly from the experience with anxiety disorders, because the experience of having an anxiety disorder was to feel something I really, really didn't like and then do something to make it go away. And of course, eventually that led to all sorts of problems. And so what I learned from that was that I couldn't make illness or problems the prerequisite for health. Because I took all the healthy things I did in my life, I only did after I felt really, 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 really bad. And so I made feeling really bad necessary to feeling good, because I never did anything for myself unless I first felt really bad. And I'm like, oh, I can't handle it anymore. Okay, I have to do something healthy. And so for me, it was learning how to do the healthy things without feeling bad first. And that was the most kind of helpful. That was the aha moment, because we get so addicted to it in so many ways, and you even see this in you see that everybody has this experience, like even if you're very stressed and you have this idea like, oh, at the end of the week I'm so stressed I go and do yoga. Well, no, you're making being stressed the price of admission to yoga or something like that. Or even if you have problems in your hospital, right, we wait until the problem comes. Okay, now we're going to sort out our communication issues, and we do this consistently, and it's a pattern. And so getting rid of that pattern, just saying, how do I build health without having to wait for disaster? Because I found I had to learn that, because I only waited for disasters. So that helps, I'd say, me the most now.
That's great, yeah. Allie, how do you find yourself building your way back up when you get burnt out? Or if you do you get burnt out?
Never. Just kidding.
Strong.
She texts me all the time. She's not telling the truth.
Actually, I know Danielle because you were on this Facebook thread with me. There was a sense actually after MEDX last year where you're at this great conference and then you go home and it's like back to reality. And it's all the things that might be triggering or difficult about being a person with chronic illness out in the real, unforgiving world. And, you come from this great amount of support everywhere you turn here and people doing amazing things and being aware and respectful of our various struggles and doing something empowering with them. And then it's like, okay, back to reality, like your boss is mad at you on Monday or something. So I think for me, it took me a while to realize kind of what Mark is speaking to. You can't help everyone if you're burning out yourself. And, things like that. Like I was spending a lot of time answering things for other people when maybe I needed some answers from somebody else too. And it was almost a distraction for me from seeking that help, whether from friends or my doctors. So I guess sometimes you do need to take a step back, and I'm guilty of it because I say I'm going to do that, and then I'm on Twitter 5 minutes later, like tweeting about MTV or something, but mostly about diabetes. And it's hard because these things are chronic, so it's like you still have to you can't just say, today I'm not going to think about diabetes. You have to wake up and think about diabetes. And so it can be hard to separate from that, but I think there are also healthy mechanisms to use so that, you can still manage your diabetes, but maybe you're not thinking about diabetes 24/7. So sometimes the social media hiatus is needed, or just, I'm not going to write XYZ number of blogs this month. I'm going to blog when I feel like it. It's ultimately we're all doing these things because we want to connect with others and have a good purpose in the world, but there doesn't need to be this like structure to it that makes you burn out. You have to be aware of taking care of yourself first, and then you're able to help other people too. And maybe I think a big thing is, having someone just admit that. Like I kind of like when I see a prominent diabetes blogger say, I'm sick of blogging right now. Like, I'm going to take a break for a day. It's like that authenticity speaks volumes, and sometimes you don't need the shining example of the disabled person who climbs Mount Everest. And that's an inspiring person, but it's also not on my level personally. So it's like, I just want somebody who's going to tell it like it is. And I try to remember that. And also in the moments of burnout, what can be nice to help me refocus is, realizing you might not, be president of the United States saving the world sort of thing, but you have these little moments where somebody emails you and says, thanks for doing the panel at MEDX on mental health and chronic illness, because it made me realize that I need to seek help again. It makes the conversation normal. So that those little moments are big moments into why we all advocate and, pay it forward because somebody's helped us in the past.
So I think we only have a few minutes left. Oh, we have 6 minutes left. Okay. I wanted to save some time for the audience members to ask questions, because I know we have quite a variety of people in the room. Okay. We have Christopher Snyder in the back of the room.
I think the context is important because, there's just such stigma still in society. Even though we've made strides, it still exists. So I think the way that help is portrayed to people in a chronic disease management setting is important. So maybe it shouldn't be like, oh my God, your blood sugar's been high and you're burnt out and you need to immediately book an appointment with a psychologist. And it's like, oh my God, what did I do sort of thing. Instead, portray it differently. Like, a large portion of our patients talk to a social worker here. She's here if you need her. Here's her card. And let the person come to that decision, because it's not going to work if you're, chaining them to the fence and saying, talk to somebody about your problem. It's just not going to work. So sometimes you have to get to that low place and then have somebody say, here's the helping hand, so to speak, and you reach out and take it.
Yeah, actually, I'll just say one thing on that because I thought that was great. Like bringing up the professionals, so the healthcare practitioners, it is shocking if somebody is dealing with a chronic issue or a health issue of any kind, you have to talk to them about mental health because they have mental health. And the moment that uncertainty is increasing or freedom is impaired in any way, that person is going to run into mental health challenges, period. And so it's so frustrating that people are having to figure out how to ask that on their own because it should just be, it should be something that's part of any conversation. The same way that, physical fitness and physical health are going to be talked about with any kind of chronic issue. It should just be expected.
And there's a movement now for asking about domestic violence in health appointments. And I'm glad people are asking, but it's always like, so everything okay at home? Yeah, good. All right, moving right along. Like the ability to ask the question, there's got to be some kind of training on the actual asking, not just ask it, but the asking of it so that it will create a sense of trust and elicit an environment that is going to get a response. And it's the same kind of thing. Like if we're asking about domestic violence, why aren't we asking about mental health? And like you say, like if we're alive, like whatever, like we have blood, we have mental health, like ergo, it's the same thing.
Definitely.
Kind of going on that, what Sarah was saying. I mean, I can't tell you how many times the doctor said, "How are you?" And I'm like, "I'm fine. I'm great." And like an hour before, I was completely in tears. I'm not fine, but I put on a brave face because I have to, because it's so stigmatized. I walk into that pediatric cardiologist's office, and if I tell him, you know what, I'm not okay, is he going to call CPS and take my kid away from me? Because all of a sudden I can't take care of him. I was afraid to let her doctors know that I was on Prozac. I was afraid when she has to have this surgery in Chicago in the spring to let them know that I have chronic cluster headaches. And if I come to the hospital with an oxygen tank and a 15-liter per minute regulator with a non-rebreather mask, that they're going to be like, can this lady take care of her kid? There's so much shame and fear surrounding it.
All right, I think we have maybe 1 or 2 minutes left. I saw the man in the navy shirt back there raise his hand. Yep. And luckily, we have 1, 2, 3, 4 of our student leadership program members here who are either medical or pharmacy students here in the room who are trying to learn from these panel members. So hopefully they'll be a part of the future leaders who will know how to talk to their patients like we want them to. So thank you so much, everyone who came to our panel today. We appreciate you learning from us, asking us questions, and feel free to follow up with us afterwards.